Hello and welcome to Dopamine. So today for our next pediatric lecture, we'll be looking into the topic of preterm physiology. Like preterm physiology, whenever the baby is delivered prior to 37 weeks or before 37 weeks, that is the thing we use to term the delivery as a preterm. Okay, so without wasting time, let's get started. So what is the definition? So the definition itself says that a preterm baby, also called a premature infant, is the one born before 37 complete weeks of the gestation. Okay, so as we already know that full term gestation, the time is between 37 to 42 weeks. Okay, so before this, before 37 weeks, we'll be calling, if any infant is born, we'll be calling as a preterm, and after 42 weeks, we'll be calling as a post-term. Okay, post-term. So, which is regardless of the birth weight. So now we have a classification by the gestational age. Okay, so see, extremely. Let's begin from the down. So moderate to late preterm, which falls between 32 to 37 weeks, and very preterm falls from 28 to less than 32 weeks. Okay, and the extremely preterm falls under like less than 28 weeks. So many a time it happens that due to any kind of maternal issues, or like due to some sort of placental issue, abruptio placenta and all those things, we need to deliver the baby prior to like the full term. So due to some complication we may deliver. So that is the reason we called it as a preterm baby. Okay, so and we need to deal accordingly. So what are the causes? So let's look into the causes. So first is maternal factors. Maternal factors first includes the preeclampsia, which includes the HTN of the mother, hypertension, and there are the infections such as, most importantly, including the chorioamnionitis or the urinary tract infection. Okay, urinary tract infection. And then we have a poor nutrition, like if the mother resides into the low socioeconomic background sector. And then we have the anatomical issue, which is a short cervix. So these all factors are of the maternal side. So due to presence of any of this, we may deliver the baby prior to its full term. So now we have the other factors, which are the fetal factors. Okay, so what are the fetal factors? So like multiple gestation, like twins. Okay, we can have twins or quadruplets or etc, all those things. And then we'll have a fetal anomalies. We can see in the ANC profiles, like the USG, which will be done like 3 times in India. So in that we'll be able to know. And then we have the placental causes. Placental causes includes the abruption or the placenta previa. So abruption the detachment is the detachment of the placenta. Okay, so for example, this is a uterus. Okay, so sometimes it happens that the detachment takes place like this. Rupture, this is the one form, and the other, so here the blood will be collected, and the other is like this. So the blood might shed from here. Okay, so these are the abruptio placenta. And then we have the placenta previa. So presence of placenta on the cervix or near cervix, on cervix or near cervix. So this can also lead to the preterm delivery of the baby. Okay, so and then we have the maternal side. Will look the lifestyle of the mother, like if the mother is smoking, if mother has an intake of an alcohol, there is way too much stress, or there is an inadequate parental care, that time also it can lead to the preterm delivery of the baby. And there is other things which are heterogenic, which is medically indicates early delivery due to a maternal or the fetal distress. Okay, maternal or fetal distress. So in mostly in maternal we'll be looking with hypertension is there, seizures are there, eclampsia, pre-eclampsia, and all those things. And in fetal distress, like fetal distress, mostly will be focusing on the hypoxia. And then we have, what do we say? And then we have the anemia. So anemia may also lead to the hypoxia due to insufficiency of the hemoglobin to provide an adequate amount of oxygen to the fetal, and which may lead to the development. So all these are the causes which can lead to preterm delivery of the baby. Okay, so now what is the pathophysiology? So preterm infants are there. Okay, so preterm infants are born before organs or organ systems are fully mature. So in short, the preterm babies will have immature organ system development. Immature organ system development. Okay, so we need to take a proper look into that baby. We need to like put on some IV drugs in order to like mature the organs, for example the lungs and all those things, the surfactant and all those things. So the first and foremost, what all organs are involved? Okay, so first we'll be looking at the lung. So lungs are the immature alveoli and surfactant deficiency. Okay, so here it means that the alveoli, which we know that like normally it contracts and relaxes. So alveoli is immature, so it won't be able to exert the pressure out or in. So what happens is the passage of oxygen from the alveoli towards the capillaries will not be adequate. So in short, we can say that lungs are not working properly. So this all leads to like the surfactant deficiency or immature alveoli. So ultimately, if this happens, then we can say that the baby will go into the respiratory distress syndrome. Okay, so respiratory distress syndrome, and if we don't treat it, then it will lead to the death of the baby. Okay, so the other point is that brain. Okay, so brain, if there is an incomplete myelination which happens in preterm babies, so will always have the risk of intraventricular hemorrhage, IVH. So if we don't treat it, the baby will have an intraventricular hemorrhage, and that will ultimately lead to the death. And then we have a liver. In liver there will be an immature conjugation, so that's the reason it will lead to an hyperbilirubinemia. And in the GI tract, what will happen, just because it is not yet developed properly, so there will be a poor mortality. Okay, so the movement of the food will not be seen properly, so there's a reason what will happen is the baby won't get a proper adequate food. There will be not a proper peristaltic movement and all those things, so that will ultimately lead to the feeding intolerance or the necrotizing enterocolitis. So necrotizing enterocolitis is the surgical emergency in neonates. So in this we will be having three stages. First, that bacterial lineup on intestinal wall, and then there will be the inner wall of the intestine breakdown, epithelium. Okay, breakdown, and if untreated, it will lead to the perforation, and then all the liquid from the intestine will be put up into the abdomen, and abdomen distension will be seen, and it will ultimately lead to the ARDS, septicemia, septic shock, and then death of the baby. Okay, and the other thing, the other system which is included with it is an immune system. So if the immune system is underdeveloped, so it will have an increased infection risk. So let's think a bit commonly. Okay, let's think in a normal way, that if something is not yet developed, we don't have the antibiotics, we don't have the antibodies, we don't have the immune system properly developed to produce the beta cells, uh, or the helper T cells, or the eosinophil, neutrophil, basophils. So what will happen due to the immaturity of those cells? It won't be able to target the bacteria or the any kind of infection. So ultimately, it will lead to the spontaneous growth of the bacteria or whatever has caused the infection, and ultimately it will lead to the septicemia and then septic shock, and ultimately leading to the death. And then we have the other, like the thermoregulation. Thermoregulation means like it has an inadequate brown fat, so the baby will be always cold, hypothermia. So there's a reason whenever premature baby is delivered, okay, first and foremost will keep under the warmer, okay, in order to gain the adequate temperature for the proper development. And then we have the kidneys. They'll have the poor concentrating ability, so we'll be having an electrolyte imbalance. So poor concentrating ability means there will be a, what do you say, a poor ultrafiltration ultrafiltration and reabsorption, which will lead to the electrolyte imbalance. Okay, I hope that the pathophysiology is clear for you. So let's proceed further. So what are the signs and symptoms? So first and foremost, we'll be having a low birth weight, which is less than 2.5 kg, and then we have a hypotonia and weak cry. There won't be the loud cry. It will be a weak cry, as you can, like, with the appearance of the baby, you'll be able to tell that is the baby properly active, the cry is proper or not. Like most of the time in neonates, just by the appearance you can take some judgments and all those things. Okay, and the other is, the baby will have a pure suck and a swallow reflex. It won't be able to suck the milk properly and swallow the milk properly. And then we'll have the thin skin and visible veins, and then we have the languor and less subcutaneous fat. So there's a reason baby will be looking thin. And there will be a respiratory distress, for example, like grunting, nasal flaring, and chest retractions will be seen. And then we have the hypothermia, as we have already seen, the pathophysiology. And thermoregulatory systems are not yet developed properly. And then we have the hypoglycemia, and then we have the apnea or bradycardia episodes in the baby. So these are the signs and symptoms which you need to remember whenever, like, you're looking at the preterm delivered baby. All the signs and symptoms should come to your mind, and you should react accordingly when you see a patient. Okay, so now the differential diagnosis. So differential diagnosis, we can look for, like, first one is the small for gestational age, and then we have the intrauterine growth retardation, which is affected by the maternal side. And then we have the postnatal conditions like sepsis, like we have septicemia, or the hospital acquired infection, which is also known as nosocomial infection. And then we have the metabolic disorder or any congenital anomalies. Okay, so complications, what complications we can see in the preterm baby. Okay, so first we'll look into the respiratory. So respiratory, the first and foremost complication we'll be seeing is respiratory distress syndrome. Respiratory distress syndrome. Okay, so the baby won't be able to like breathe properly. The baby will be hypoxic. Why? Because the respiratory system is not yet developed, the lung surfactant is not yet developed, which will help to like inflate and contraction of the alveoli. There's a reason we'll be seeing respiratory distress syndrome, and then we'll have apnea of the prematurity, and then we'll have bronchopulmonary dysplasia. Okay, so the most important is RDS, and then we have the neurological, because brain is not yet developed, so we can see intraventricular hemorrhage. Okay, then we have periventricular leukomalacia and cerebral palsy, and as we already know that gut is not yet developed properly, so necrotizing enterocolitis, and there will be feeding intolerance, the baby will be feeding less. And then we have infections like sepsis or meningitis, because there is an improper development of the immune system. And the metabolic thing, metabolic will be looking at hypoglycemia or hypocalcemia, prone towards the fracture mode, fragile bones and all those things. And improper development, the what do we say, eyes, it may lead to the retinopathy of prematurity. And if the baby is not treated for a long term, then there will be a developmental delay or learning disabilities. So these are all are the complications that we may look. So complication, as you can see, is directly linked to the immature development of the organ systems. So you can like directly recall like these all things are not yet developed. So these are the possible outcomes of the not treating a patient. Okay, so now investigations. What all investigations will do? Investigations will do is CBC, complete blood cell count. We'll be seeing for C reactive protein and blood culture if we have a sepsis suspected, and then we need to see the blood glucose, calcium, bilirubin in order to rule out the metabolic disorders. Okay, and then we have the chest X-ray if there is any kind of respiratory distress. Okay, and then we have the cranial ultrasound for intraventricular hemorrhage, and then we'll analyze the ABG, okay, for the ventilated infants, whichever patient we have put on the ventilator, for them only. Okay, and then we have the echocardiogram, okay, for PDA. And see, now over to the management or the treatment. So what initial steps you will do when there is a premature baby which you have delivered? So first and foremost, initial stabilization in the delivery room itself will be looking. So first is a thermal protection. Okay, so thermal protection, like warm room should be there, a plastic wrap or the radiant warmer. In India we mostly use the radiant warmer, we keep baby under the warmer. And then we need to analyze the airway and breathing support, CPAP or intubation, and we need to administer the surfactant if needed. And then we have the circulatory support like delayed clot clamping, fluid bolus if hypotensive, and all those things. So these are the first thing that will be looking in the delivery room. And after that you'll be shifting the patient or the baby to the NICU, NICU. Okay, so here we'll be using a respiratory support like CPAP or the mechanical ventilation and surfactant therapy for the lung maturity. Okay, and then we'll give the nutrition support, just because the swallowing and sucking reflexes are underdeveloped. Reflexes underdeveloped. Okay, and like initially we'll give the IV fluids like glucose and electrolytes, and then enteral feeds with express breast milk, or like fortifiers you can include or exclude. And then we have the thermoregulation. Thermoregulation is incubator care, and there is a regular temperature monitoring of the baby, and then we give the antibiotic if infection is suspected. So these are the dynamic things. Okay, so if you suspect any kind of like infection, or say like increased total increased total count, or there is an increase or decrease in any kind of differential counts, that time you can take the actions. Okay, and then we need to monitor the glucose, bilirubin, calcium, and electrolyte levels, just to be sure that and all the things are at the perfect level. And if any increase or decrease is there in the point, so we can take the adequate action to treat the baby. Okay. And long term support, what we'll do, so first and foremost, we'll give the vitamin supplementation like vitamin D and vitamin iron. Why? So as we have seen, there is an hypocalcemia. Okay. So hypocalcemia, so it will lead to fragile bones. So these fragile bones can be easily cracked. So in order to achieve or increase the calcium in the bones, will start the baby on vitamin supplements and iron supplements. And upon the follow-up screening, we need to do the retinopathy of prematurity, hearing, and neurodevelopment. And the parental education is also important, like feeding, hygiene, and danger signs of the baby. So I hope that premature deliveries and premature physiology, you have understood it well, and I hope that everything is clear. And if you have any kind of questions, or if you have any other question rather than this, please feel free to comment it. And thanks a lot for watching. Thank you for watching, and please do make sure that you like, share, and subscribe to your medical friends. And we'll be starting giving up the notes free of cost to each and every one of you. So be connected so that you are aware that we have put up all the uploaded the medical notes, so that it's easy for you to read. Okay. So have a good day, and thanks a lot again for watching. Bye bye.